answer the rest of the questions in the chat because there are some really good questions here about prometrium, perimenopause, and we will move on to our next speaker. Dr. Tina Liang is going to talk to us about PCOS, which is always a popular topic, and obesity, which is unfortunately an increasing problem as well. Dr. Liang is one of our wonderful REIs at our Edmonton facility at PCRM. Dr. Liang did her undergraduate and medical degrees at the University of Alberta. She also completed her residency training in obstetrics and gynecology at the University of Alberta, and then she traveled to Western University for her fellowship training in reproductive endocrinology and infertility. She's certified by the Royal College of Physicians and Surgeons of Canada in OBGYN and REI. And I'll ask Dr. Liang to go ahead and share your screen, please.
Thank you very much for that introduction. All right, so the topic I'll be speaking about today is polycystic ovary syndrome and obesity. Each of these are big, complex topics to cover. So in the short amount of time that we have, hopefully I'm able to condense it down to the most relevant points for all of you. So the objectives I'd like to cover today are pathophysiology of PCOS and its association with obesity, the diagnosis and risk assessment for PCOS, touch on the lifestyle interventions recommended in PCOS, as well as pharmacologic agents for the management of infertility in PCOS. Much of the content of what I'll be speaking about today is summarized from the International Evidence-Based Guideline for Assessment and Management of PCOS, which was published in 2018. It's a very comprehensive 200-page document that's been endorsed by ESHRE as well as ASRM, two of the major societies in reproductive medicine. So the first question we'll talk about is, what is PCOS and how is obesity related? So PCOS is a common condition affecting 8 to 13% of reproductive aged women. It presents with diverse features, including psychological, reproductive, as well as metabolic. Obesity is also, unfortunately, becoming increasingly common, with 25% of reproductive age women in Canada being overweight and 19% being obese. Many of obesity's health effects are mediated through insulin resistance, hyperinsulinemia, as well as its associated metabolic dysfunction. And so, how are the two related? The close association between obesity and PCOS is supported by the fact that up to 88% of women with PCOS are overweight or obese. Women with obesity are nearly 3 times more likely to develop PCOS. And as well, there's emerging evidence for a shared genetic architecture between obesity, the various metabolic traits, as well as PCOS. The pathophysiology of PCOS is complex, and that's not my intention to cover all of that today, but there is a major association with insulin resistance. So although the insulin resistance in PCOS occurs independently of obesity, obesity greatly increases the degree as well as its subsequent effects. And so weight gain and obesity does play a key role in the pathogenesis of PCOS. So the ways in which weight gain contributes to metabolic dysfunction in PCOS include an increase in adipokines, which are just cytokines released by adipose tissue, obstructive sleep apnea, as well as an increased visceral and hepatic fat. And these are all related and associated with increased insulin resistance. As well, the insulin resistance and increased insulin incompensation associated with the weight gain also contributes to hyperandrogenism in PCOS by insulin's stimulatory effects on ovarian androgen production, as well as adrenal androgen production, and by insulin suppressive effects on hepatic SHBG, sex hormone binding globulin, which increases free androgen levels, as well as enhanced 5-alpha reductase activity in the periphery. Excess weight also influences the reproductive dysfunction in PCOS through increased insulin effects. And these include premature granulosa cell luteinization, enhanced ovarian androgen production, and both of these ultimately lead to arrest of follicular development and subsequently oligo-ovulation, oligomenorrhea, and impaired fertility. So how is PCOS diagnosed? The 2018 International Guidelines for PCOS endorses the Rotterdam criteria for diagnosis in adults. It requires 2 out of 3 of the following criteria. So number 1, oligo and or anovulation. Number 2, clinical and or biochemical signs of hyperandrogenism. And number 3, polycystic ovaries by ultrasound. And I'll go into a little bit more detail what each of those encompass. In adolescence, it's a stricter criteria, so it requires both irregular cycles as well as hyperandrogenism, with ultrasound not being indicated in this population, just due to the high incidence of multiple follicles in this age group. As well, PCOS is a diagnosis of exclusion, and so other conditions that may present similarly should be ruled out, such as thyroid disease, hyperprolactinemia, congenital adrenal hyperplasia, mainly the non-classical type, androgen secreting tumors, as well as hypergonadotropic hypogonadism or ovarian insufficiency. The definition of irregular menstrual cycles varies by a person's life stage according to the guideline. So any irregularity is considered normal in the first year post-menarche. In the period of 1 to 3 years post-menarche, it's considered irregular if the cycle lengths are less than 21 days or greater than 45 days. In the period of over 3 years post-menarche to perimenopause, it's considered irregular when cycle lengths are less than 21 days or over 35 days. As well, if someone has less than 8 cycles per year. And as long as any cycle is over 90 days in duration, at least 1 year post-menarche, that's also considered irregular. Primary amenorrhea is defined by lack of menses by age 15 or over 3 years post the initiation of breast development. Clinical hyperandrogenism is defined as clinical symptoms of acne, alopecia, or hirsutism. And in adolescence, this should be severe acne or hirsutism. The Ludwig Visual Scale, as well as the Modified Freeman-Galway score, are scoring systems for the severity of alopecia and hirsutism, but practically speaking, these are more used in research settings. And so I think patient complaints of relative severity are probably more important. Biochemical hyperandrogenism is most useful if there are no clear signs of clinical hyperandrogenism. And these can include elevation in any of the following. So calculated free testosterone, free androgen index, calculated bioavailable testosterone, DHEAS, as well as androstenedione, which are mainly adrenal sources of androgens, can be measured if total or free testosterone are not elevated. And androgens shouldn't be measured if someone is on hormonal contraception. A 3-month withdrawal period is recommended. Polycystic ovarian morphology, the criteria on ultrasound. So if we're doing this, or this assessment is optional, not necessary if someone already has irregular cycles as well as hyperandrogenism. but doing this will identify the complete PCOS phenotype. And if doing this assessment, an endovaginal ultrasound is preferred. It's defined as over 20 follicles per ovary and or an ovarian volume greater than 10 milliliters in either ovary. If using older ultrasound technology or transabdominal ultrasound only, it's best to use the criteria of ovarian volume. And the guideline is also clear that ultrasound shouldn't be used in the diagnosis in adolescents or in those less than 8 years post-menarche due to the high incidence of multifollicular ovaries in this population. And so this is the algorithm for the diagnosis from the 2018 guidelines. Basically, in summary, biochemical hyperandrogenism and ultrasound assessment of polycystic morphology are not necessary or are optional if someone already has fulfilled both criteria of irregular cycles as well as clinical hyperandrogenism. Some other notes on the diagnosis. So AMH is not currently used, although it is being studied. The guideline recognizes that PCOS is an insulin resistant and metabolic disorder, but tests for insulin resistance lack accuracy and shouldn't be incorporated into the diagnostic criteria at this time. The guideline also emphasizes that for adolescents with features of PCOS, but don't meet the full diagnostic criteria, an increased risk could be considered, and then reassessment recommended at or before full reproductive maturity, which is 8 years post-menarche. So what are some other recommended assessments and screening tests once we've diagnosed PCOS? So we do know that women with PCOS have an increased incidence of cardiovascular risk factors. It's still unclear whether they truly have a higher risk of cardiovascular disease, but it's important to assess for these risk factors. And so regular monitoring of their weight, specifically height, weight, BMI, and ideally waist circumference is recommended on a 6 to 12 month basis. Blood pressure should be measured annually, and in overweight and obese women, a fasting lipid profile. Due to the increased incidence of impaired glucose tolerance, type 2 diabetes, as well as gestational diabetes, screening for these conditions are also recommended at baseline. The oral glucose tolerance test is preferred if there are other risk factors present, and it should be offered pre-conception or at less than 20 weeks gestation if there are other risk factors as well. Screening can also be considered for obstructive sleep apnea, especially if someone has symptoms, although wide-scale screening is not currently recommended. In terms of endometrial hyperplasia and cancer, this is also important to keep in mind because women with PCOS do have higher risk of this. Although routine screening is not warranted, we should have a low threshold for screening them, typically in the form of an endometrial biopsy if they have signs of thickened endometrium, prolonged amenorrhea, abnormal bleeding, as well as obesity. The optimal prevention of endometrial hyperplasia is still unclear, but practically speaking, usually a combined hormonal contraceptive or progestin therapy is recommended if cycles are greater than 90 days in length. So what about lifestyle interventions and how do they benefit reproductive function? So the goals of lifestyle interventions are to reduce weight, central obesity, as well as insulin resistance. Achievable goals should be set, so 5 to 10% weight loss within 6 months does yield significant clinical improvements and is considered successful weight reduction. The goals set for patients should be SMART, so specific, measurable, achievable, realistic, and timely. Because lifestyle interventions take time to achieve, many patients might ask, what benefit would weight loss have on fertility? So I'll mention a few studies looking at this. This was a secondary analysis of 2 randomized controlled trials done in women with PCOS, specifically looking at pregnancy rates after ovulation induction. The PCOS 2 trial, those women were treated with ovulation induction immediately. And in the OWL PCOS trial, one of the experimental arms randomized women to a 16-week period of lifestyle intervention. And so the combined secondary analysis of these 2 trials showed that in overweight or obese anovulatory women with PCOS, a 5 to 10% weight loss achieved after the period of lifestyle intervention was shown to increase the ovulation rate in response to clomiphene, as well as increase the cumulative live birth rate after 4 cycles of clomiphene. In addition, 2 other randomized controlled trials looking at the effect of lifestyle interventions have been done in obese infertile women, although not all of them necessarily had PCOS diagnosis. But in both of these trials, they did show improved spontaneous conception rates following the lifestyle interventions. And so how are lifestyle interventions best achieved? Ideally, it is through multiple components, including behavioral, dietary, and physical activity. I think it's helpful to keep in mind for patients that the benefits from physical activity do occur even independent of the weight loss that's achieved, because the physical activity will help to decrease the insulin resistance. Beyond just purely lifestyle interventions, other strategies can also be considered to aid in weight loss as well as improve metabolic outcomes. So the role of metformin in PCOS, according to the new guideline, is mainly for the management of weight and metabolic outcomes, and it should be considered in adult women with PCOS who are overweight, in addition to lifestyle interventions, although use in this setting is still off-label. Anti-obesity pharmacological agents can also be considered, although their safety is still unknown during pregnancy. And bariatric surgery is also considered second line for severe obesity and in those who are resistant to intensive lifestyle modification and/or pharmacotherapy. However, it's recommended to delay conception for at least 12 to 24 months due to concerns about adverse pregnancy outcomes during the period of the most rapid weight loss. And so what are other management options beyond just lifestyle for PCOS and infertility? Prior to initiation of fertility treatment in women with PCOS, it's still important to consider an assessment of other infertility factors. And so a semen analysis is recommended. And tubal patency assessment, the timing of this testing can be individualized, but it should be considered prior to ovulation induction if there are risk factors for tubal pathology. And so these would include previous abdominal or pelvic sepsis or surgery, recurrent pelvic pain, history of sexually transmitted infections or PID, as well as endometriosis. And so the first line agent, pharmacologic agent for ovulation induction in PCOS is letrozole. It's an aromatase inhibitor. The mechanism of action is thought that it prevents aromatase-induced conversion of androgens to estrogens, including within the ovary itself. And thereby, it increases gonadotropin secretion that stimulates ovarian follicular development. Compared to clomiphene citrate, which has been used longer for ovulation induction, Letrozole has shown an improved ovulation rate, pregnancy rate, as well as live birth rate. There's been no difference seen in multiple pregnancy rate or miscarriage rate, although the use of letrozole for ovulation induction is still off-label. The starting dose for letrozole is typically 2.5 milligrams daily from cycle days 3 to 7. We typically advise intercourse every other day from cycle days 10 to 20, or this could be timed using ovulation predictor kits. Confirmation of ovulation using a mid-luteal phase progesterone level is recommended. And an indication for dose increase would be anovulation, and typically we would increase the dose by 2.5 milligram increments. The maximum dose is typically 7.5 milligrams daily. Multiple pregnancy rates is typically about 5%, with risks of higher order multiples being less than 1%. Some common side effects would include hot flashes, fatigue, dizziness, headaches. There's been no evidence showing an increase in congenital anomalies. Other agents to consider for ovulation induction would include clomiphene citrate, which is used very similarly to letrozole. Metformin alone can also be used, although letrozole and clomiphene are much more effective than metformin alone. Metformin in combination with another oral agent can be considered, especially if someone is resistant to the other agent alone, especially clomiphene. Some other practical principles to keep in mind with ovulation induction. So pregnancy should be excluded prior to initiation of any of those oral agents. And it's recommended to avoid unsuccessful prolonged use. So over 6 ovulatory cycles without a successful pregnancy would be an indication to refer typically. Some second line options for management of infertility in PCOS would include gonadotropins, which requires more intensive ultrasound monitoring, laparoscopic ovarian drilling, and IVF is also an option, typically third line, unless there's some other absolute indication for IVF as well, for example, male factor or tubal factor. And so this is an algorithm taken from the guideline that summarizes the management of infertility quite well. And so in conclusion, the pathogenesis of PCOS is complex, with insulin resistance playing a major role, and hence it's a close association with obesity. The diagnosis of PCOS is done using the Rotterdam criteria with exclusion of other conditions. Women with PCOS have increased rates of metabolic risk factors, so screening should be offered. And lifestyle interventions are recommended for those with PCOS and obesity to decrease weight and insulin resistance and improve their reproductive function. And letrozole is the first line agent for ovulation induction for the management of infertility. And thank you very much for your attention, and I welcome any questions.
Thank you so much, Dr. Liang. That was a really great review of a very long guideline. Again, we've got speakers here saving us hours of guideline reading time. So let's get into some questions here. We have about 4 minutes. There is a question on thoughts about using Ozempic in patients with obesity and PCOS.
I do know that I think there are 3 approved agents in Canada. I'm not sure that Ozempic is like I think is used in an off-label setting, and I have seen it used. The guideline doesn't have any specific recommendations aside from anti-obesity agents should be considered in a general kind of treatment of obesity setting guideline. So, but I think certainly to aid in weight loss, if that's the goal, prior to initiation of fertility treatment, it can be considered as an option.
And Dr. Liang, there are a few questions here about specific diets, whether that should be keto or plant-based diet. Do you have any specific suggestions based on the guideline about diet for PCOS-related infertility?
The guideline did have a thorough review of the evidence on this topic, and there wasn't a specific diet or diet kind of plan that showed significantly better outcomes.
Perfect. And again, somebody asking about the anti-obesity medications and whether you're aware of any studies or adverse pregnancy outcomes for women who conceive while they're on an anti-obesity medication. And there's also an add-on here about bariatric surgery and how long post-bariatric surgery that one should wait before conceiving.
So generally, I currently don't know of any evidence of adverse pregnancy outcomes, although there just hasn't been enough studies. Typically speaking, it's not necessarily recommended that someone continues trying to conceive while on these anti-obesity medications. And so we just don't have enough data about the safety of it in pregnancy. In terms of how long to wait after bariatric surgery, the recommendation is at least 12 months or 12 to 24 months, as I mentioned, just because there's a concern about the nutritional deficiencies during the most rapid period of weight loss can increase adverse pregnancy outcomes, things like IUGR, preterm births, things like that.
Perfect. And then we have time for one more question. So in people with PCOS who get pregnant, regarding the diabetes screening, you indicated that we should do gestational diabetes testing prior to 20 weeks. And then would you recommend testing again at the 20 to 24 week mark?
So yes, if they screen negative early on, it's still recommended to screen them at the usual time in pregnancy as well.
Perfect. Now there are a couple of more questions there in the chat. If you wouldn't mind, Dr. Liang, answering those for people.
Of course.
And then just to stay on schedule, we will move on to our next speaker. Thank you very much. So I have the pleasure of introducing my practice partner and co-director of PCRM, Dr. Jeff Roberts. Dr. Roberts is going to talk to us about infertility and recurrent pregnancy loss for the community physician. Dr. Roberts has BSc and MD degrees from the University of British Columbia. He completed his residency in obstetrics and gynecology at McGill, and then a 3-year fellowship in reproductive endocrinology and infertility at the Center for Reproductive Medicine and Infertility at Weill Cornell Medical College in New York. Dr. Roberts is board certified in obstetrics and gynecology by the Royal College of Physicians and Surgeons, and his focus is on uterine surgery, fertility preservation, and in vitro fertilization. So I'll ask Dr. Roberts to go ahead and share your screen.
Thank you, Caitlin. And a personal thank you for everyone for the great attendance this year. It's been just a phenomenal response, and we're excited to deliver this again this year and hopefully years to come. So I want to cover the workup of infertility and recurrent pregnancy loss, which is obviously both big topics, and there will be a little bit of overlap with the other speakers, but some of these topics are definitely merit some duplication. So the definition of infertility is by all societies a failure to achieve successful pregnancy after 12 months of 12 months of unprotected intercourse, or importantly, the presence of impairment to a person's capacity to reproduce. So if there's other findings that are obvious, most pregnancies are going to occur in the first few months, but at the 1 year mark, about 85% of patients are going to have conceived. And importantly, if you leave these patients, if all their testing is normal for another year, about half of them are going to conceive. So it's not there's not going to be a mad rush at the 1 year mark to get into treatment. And age has made its way unofficially into the definition. The person's chronologic age is critical. And the young group, which we define as under 35, we use the 12-month mark. Between 35 and 40, we consider testing after 6 months. And any patient over 40, we believe should seek immediate investigations, and the insurance companies in the US also agree with that. So that testing sometimes starts quite early. So when is a good time to start this workup? Well, infertility, of course, if you meet the definition, age, as we mentioned. If there's something in the history or physical findings suggestive of an obvious problem, menstrual irregularity being one. For instance, PCOS patients are often told at a young age that they're going to have infertility. So I think most of them just present with that chief complaint. Or if there's pain, we're obviously looking for conditions like endometriosis. Any risk for tubal disease, previous pelvic infection, of course, ectopic pregnancy, male factor, if it's suspected. Dr. Bach went through all of this, of course. We would commonly see a reduction in libido, maybe infertility with a prior partner. Same-sex couples, of course, if there's no sperm or eggs at home, they're going to have a problem, and they're going to have done their research usually ahead of coming in. And the insurance companies, the payers often still support treating after 6 months of insemination. If they're not pregnant, they're never going to force a patient to wait a full year. So there's for your patients, for counseling purposes, I recommend using a site like this to get a sense of what their chances are before you dive into certainly treatments or invasive testing. And this is one site that will give you that live birth rate for your patient, give you a sense of what the problem is at home. So let's break it down into 3 components here: eggs, anatomy, uterus and tubes, and fertilization. And within eggs, Dr. Dunn's touched on a lot of this, of course, but within eggs, there's age, ovarian reserve, and importantly, we need an egg, which is ovulation. So the classic study is within populations of women that don't use contraception. The Hydrite study was probably the strongest one, this top curve. But the national data supports that there's a decline in deliveries with time, and this becomes more dramatic after age 35. And it appears that there's 2 components to that, and that's the declining number of eggs and that declining quality of these eggs. And not to steal from Caitlin's slides here, but this is a good example of the decline of eggs with time. We seem to have a peak as a fetus around 18 weeks gestation. That's about 6 to 7 million eggs. At birth, we've already dropped down to about 1 million eggs. And by the time of the first period, about 300,000. Each month, there's hundreds of eggs that are lost. We have no control over that, no matter what's going on in our life, and only one survives to be ovulated. So there's approximately 300 to 400 ovulations per lifetime, and at menopause, there's a few hundred. And whether the patient's on birth control pill or protected by pregnancy, potentially, you're going to have that loss of eggs. Quality is widely believed to be related to aneuploidy. So too much or too little DNA within the egg is going to cause it not to work. It's either not going to get the patient pregnant in the first place, in most cases, or cause miscarriage. So this is data from PGT, aneuploidy, which is biopsy of embryos with IVF. So now we have great data to show this effect. And you'll see it declines more rapidly after age 35, like we see in the population studies. And importantly, even at a very young age, even with egg donors, most eggs are abnormal. So there's this myth amongst our patients that the women walking the street have a 100% pregnancy rate. which is far from the truth. So it's a problem in all patients. And this is mirrored in the outcomes with IVF, and this is strongly shown in the American data. Our American colleagues are very good at collecting data from IVF, the SART database. And you can see a decline in the implantation rate, which is the ability of a single embryo to work with time, and an opposite increase in the risk of miscarriage with time from IVF. So we don't have a test of quality. We do have tests of quantity. It's a common misconception amongst patients that we have a quality test, which is the 3 tests you see here. These are purely tests of quantity, and that's basal FSH, the size of the ovary or antral follicle count, and AMH. So FSH is produced from the pituitary gland, from the brain, closely linked to egg and sperm production. It's actually what we inject in patients to create eggs for IVF in our treatments. It's free, so it's MSP insured in all provinces. It's lowest at the beginning of the cycle, and you can actually measure it on day 1, 2, or 3. So if a patient shows up on day 3, don't have them come back the next month. It's predictive on any of those days. We do an estradiol with it more to know where they're at in their cycle. So you want the estrogen to be low when they do it. It's estrogen's poorly predictive of outcome. FSH is not a test of whether a patient will get pregnant. So it's common misinformation to tell patients they're sterile with high FSHs, and that would only be the case if they're in menopause. But high levels are very predictive of a poor response with IVF. So there's a strong positive predictive value there. Very high levels are predictive, though, of low birth rates with IVF. And like Dr. Dunn showed with this graph, if you just follow it all the way to the end, you'll see at all ages beyond an FSH of 15, there's no pregnancies. So this is strong evidence to back away from invasive treatments like IVF if FSH is too high. AMH is, antral follicle count is essentially looking at the size of the ovary. And the specific measure is the follicles at the end of development, the end of folliculogenesis, when they're appearing as little black dots within the ovary in ultrasound. They measure between 2 and 9 millimeters, and the normal value is between 8 to 20 when you look at both ovaries together. Traditionally, we do recommend it in the early follicular phase. That's when the ovary is the quietest. Obviously, later on in the cycle, you're going to get eggs developing, and it can skew the size of the ovary, but practically we do it throughout the month just for ease of scheduling of these patients. And like the other measures, you're going to get a more rapid decline in the number over the age of 35. And it's a valuable tool we use for dosing patients as well for treatments like IVF. The most important tool that we have presently would be AMH. And this is seems to be the hormonal gatekeeper within the ovary. And it limits the cohort of eggs each month that are available for recruitment. So essentially it prevents us from having triplets and quadruplets every month as humans. So it does control the ovary's ability to make eggs. It's secreted from the early follicles that we sometimes see on ultrasound. It is very importantly stable through the menstrual cycle. So you can send the patient at any point in the month and it's going to give you a valid result because it's coming from the follicles that aren't being stimulated that month. And it can be suppressed in some situations, but for the most part, it's quite stable, no matter what's going on with this patient. And importantly, I think there was a question earlier, it actually, it's quite sensitive earlier on in life, so it starts to decline prior to the other markers, namely FSH. So FSH is quite a late finding. In BC, it's not covered. It's about $70 through Life Labs. In Alberta, I believe it's still covered. It's a very good measure of egg quantity, and on a practical level, we use it for predicting response from our treatments. Most importantly, IVF. We want to make sure it's being done safely. Very high levels are predictive of over-response and the risk of ovarian hyperstimulation syndrome. Low levels thought to be less than 7 picomoles per liter are quite predictive of poor response, which is generally defined as less than 5 eggs from IVF. With IVF, we're generally aiming for as many eggs as we get in a whole year, which would be around 15 to 20, to give a reasonable chance of not just one baby, but hopefully 2 with all the embryos that are frozen. Very low levels, less than 1 picomole per liter, are actually predictive of very poor outcome from IVF. So that's where you start getting a drop in pregnancy rates. Like we had mentioned earlier in the session, very poor predictor of egg quality. So it's not a predictor of aneuploidy or live birth. So don't tell your patients they're not going to get pregnant naturally. It's not great at predicting outcome from our IUI treatments. IVF, if it's very low, like I mentioned, can be predictive. It doesn't seem to be a great predictor of when menopause is going to occur, but we do use it in situations where the ovary's been injured, primarily in our fertility preservation patients or cancer patients that are having their ovarian reserve tracked with time. So we do use it for counseling in that setting. So at standard doses, which would be considered around 150 units of FSH, you can get a nice direct relationship between AMH and the number of eggs that are recovered from IVF. And with the combination of AMH and AFC, we have powerful tools now to really fine tune what we're doing with our IVF stimulation to make it safer for patients, but also optimize their outcome. So you'll see with age, you're going to get a decline in AMH and see the low, normal, and high range at each age, and then use this to make dosing decisions for the patients with IVF. And you'll see as they get older, even in the high range, they're starting to drop down below a level that we get low responses. So even in the PCOS patients that are over 40, you're going to start to get lower responses with IVF, and that makes it more difficult to get them pregnant. But 7 picomoles is generally considered the point where you start getting that effect. So in a patient that's coming to be at least treated through the facility, we want to see their FSH under 10. We want to see an antral follicle count over 8 when you look at both ovaries, and we want to see the AMH up over 7. So let's talk about ovulation. So classically, ovulation would be ovulatory cycles would be regular, predictable, and have a consistent volume and duration of period each month. So the history is critical. We actually rely more on the history than anything else. And eumenorrhea would be defined as between 21 and 35 days. And ovulatory cycles would be irregular, unpredictable. The patient doesn't know when they're going to show up, and typically defined as greater than 35 days. But most patients, in my experience, are around 28 to 30 days, and I'm sure you would agree. So this range of 21 to 35 is quite broad, in my opinion. Dr. Liang had covered, obviously, this very well, but being the most common cause of ovulatory disorders, problems, over 80% PCOS has to be considered to meet 2 of the 3 criteria, anovulation. And interestingly enough, about 20 to 30% of these patients actually have regular periods. So it's sometimes important to do the ovulatory testing in them. Polycystic ovaries on ultrasound, and then some evidence of high androgen levels. And a lot of times we're using clinical criteria if the patient complains of high androgen levels in terms of hair growth, so oily skin, that sometimes is enough. And then, of course, the broader issues that aren't within the criteria that are important for health and the pregnancy, reproductive, metabolic, and psychological, as Dr. Liang had covered very well. And we must exclude other causes of high androgen levels. An important concept, though, that I see in a lot of my patients, and sometimes merits treatment in the same light, is the fact that PCOS may be a continuum. There's some patients that are more occult. Approximately 20% of patients do have menstrual irregularity, but up to 60% just don't meet the criteria for PCOS. And I think they do merit investigation and treatment. Regular menses doesn't mean that they're ovulating. Some mild phenotypes represent about 10 to 15% of anovulatory patients. And these may make up those old syndromes we hear about, luteinized unruptured follicle syndrome, where the hormone fluxes aren't quite there to get the egg out, and the egg stays in the ovary, or luteal phase defect, where the second half of the cycle is too short and may prevent pregnancy. But they all stem back to the ability of the ovary to ovulate. So history is important. At home, I think it's still important for patients to follow their basal body temperature. Obviously, quite a late finding. The thermogenic rise is occurring 1 to 5 days after ovulation. So it's a retrospective thing. It's too late by the time the temperature goes up, but it does give us the ability to track them to see if they're ovulatory. Mid-luteal progesterone still important. Rises about to its peak around 7 to 8 days after the LH surge. It's very pulsatile. You get rapid swings in serum levels even over the course of an hour. So you have to be aware of that. It is used clinically to document ovulation, most importantly. Letrozole patients, where we're sending them home and tracking to make sure that it's working. You don't have patients at home using a certain dose unnecessarily, so we'll have these levels that our nurses follow up on. But importantly, there's no such thing as a good level. Often patients want to know what a good level is, or if their level's appropriate. There's positive and negative because of these the pulsatile nature of it. So you just want it above 10, but there's no such thing as a good level. So any patient that has ovulatory dysfunction, we do what's called a PCOS workup. We book all these patients for ultrasound, whether it's with us or on the outside, to look for PCO. Ovaries, we want some level of assessment of ovulation. Most patients will have an FSH-LH estradiol level in the early follicular phase. And AMH is not part of the criteria, as Dr. Liang had mentioned, but gives you a sense of just how many eggs they have. And for counseling, at least, you can tell them they have a lot of eggs. You're just not getting one out. But it definitely demonstrates the pathophysiology. And then some level of assessment of hyperandrogenism and screening for diabetes, obviously important. I don't always do a HSG. If they're coming to you and they don't have ovulation, that's sort of your problem. I don't always feel the need to put them through that test. So recurrent pregnancy loss is been defined now by our European and American colleagues as 2 miscarriages before the 20-week mark. And this is based on evidence that outcome is the same, whether it's been 2 or 3 losses. It's about 2 to 3% of our couples, and over 50% of cases are unexplained. The likelihood of a live birth is going to be based on the number of losses they've had, and this table may help you counsel your patients. And obviously age is important, as we mentioned, and the number of losses to get a sense of what's the chances of them eventually having a live birth. Importantly, it's normal for about 70% of conceptuses not to achieve viability, and 50% of those are lost undetected. And this is thought to be, again, related to aneuploidy. So if you do very detailed testing of these pregnancies with microarray testing, you can bring that unexplained number down to about 5% based on this study, but at least 50% of losses are aneuploid if you do more detailed testing on them. And the most common cause would be a single chromosome aneuploidy. So the workup of infertility, recurrent pregnancy loss is here. You always want to at least a karyotype on both partners to look for rearrangements of the chromosomes, balanced translocations. Sometimes you can pick up mosaics, not uncommonly mosaic Turners we see. You want to assess their anatomy, HSG, pretty standard test. On site, we do 3D sonohistograms to look at the uterine architecture a bit more closely, less commonly pelvic MR. But you're looking for uterine anomalies, intrauterine abnormalities in the upper third of the cavity. And you want to rule out antiphospholipid antibody syndrome. And I'll post on the slides. I've hidden it for this talk, full criteria. And high and low thyroid function associated with poor outcome. We see mostly hypothyroidism, which would be associated with early loss. So we always want to correct that. Diabetes, of course, especially with A1C above 8, associated with malformation and miscarriage, and prolactin, important to manage because that can cause luteal phase defect and early loss. We don't routinely do serum progesterone, and thrombophilia is not part of the workup, and nor is ID screening for infectious disorders. So I just want to touch on a couple fairly controversial topics within recurrent loss. This is a study hot off the press looking at the obvious question of if aneuploidy is the most common cause of problems, and why not just genetically screen all embryos and then you'll solve it. So they looked at using logistic regression, a large sampling of the SART database to control for other risk factors, and did find that in patients that had genetic testing, PGT of embryos, the live birth rate was higher. And there was a slightly lower risk of spontaneous loss. And this is the first time this has really been demonstrated to any degree. If you look, it becomes more pronounced as the patients get older, which is critical. Limitations, of course, it's raw data from clinics. We're not looking at embryos that have not been biopsied, which is a common criticism. And the effect on loss was small. But I think it's a study showing that we're doing the right thing in our clinical practice, that there is an effect there, potentially, which is encouraging. The other, there's always going to be questions on, is whether to give these patients progesterone. We use, you may know, progesterone routinely in our treatments. When you do IVF, you do disrupt progesterone production, so that does increase live birth. But it's unproven for unexplained recurrent pregnancy loss, and there's strong randomized trials to show that versus placebo. Oral micronized progesterone has very poor bioavailability, so it's not commonly used. We'll always use it vaginally. And synthetic progestins, which which are not available in Canada, there is some evidence for. I don't know when they would be available here, but they're understudied and have a smaller representation within our studies. But importantly, just using progesterone on the creams on the skin are probably of limited benefit. And you generally are going to get very low serum levels, much lower than what you would have to allow for a secretory endometrium. So assessment of anatomy comes down to essentially two tests as basic screen. HSG is a fluoroscopic procedure. So you're injecting dye through the uterus. You want to watch it flow out through the tubes. There's three films, a scout, which is just the plain film before the injection. You inject to get the initial film, which is the contour of the uterus, and then the tubes. So you want to see, obviously, flow from both sides. Generally performed around day 10 of the cycle. Prep the patient with a good dose of ibuprofen. So I tell them to take more than what it says on the bottle, like 600, 800 milligrams. Very sensitive test for tubal disease. And importantly, if they have any risk factors for infection, you want to cover them, namely for hydrosalpinx. About 3/4 of the tests are going to come back with patent bilateral tubes. 15 to 20% are going to have blocked tube on one side, the rest blocked on both sides. Very high sensitivity, up over 80%. Unfortunately, it does have a high false positive rate, and it's usually unilateral blocks. So that's related to, we think, corneal spasm or preferential fill. It's an uncomfortable test. It causes cramps, so the dye is going to go out through the other side. Very low false negative rate. So if the tubes are open, they're unlikely blocked from the test. That makes sense. So very high detection rate for obstruction. This is high false positive rate. So you can repeat the test, and we do offer that, but don't get many takers just because the test hurts, and we don't come and do surgery. So we will often ignore that side of it, depending on the other features. And you can screen for chlamydia, which we don't do commonly in Canada, just to make it a bit more sensitive of a test. It's not a great test for the inside of the uterus, so the sensitivity is not as great. Low detection rate, high false positive rate. You do get a lot of false positives, so it does generate more surgery for sure. And generally hysteroscopy is the next step beyond that. But we do offer in-house the option for, and it is a privately test, doing a sonohystogram, just to improve on that false positive rate. Uterine malformation requires other tests, namely either a 3D ultrasound, which we can do on site as a sonohystogram or as a plain test, or a pelvic MRI, less commonly surgery for uterine malformations. Ultrasound, very much a tool of the trade for us. It's hard to get through us without an ultrasound at some point. Very good screen for a variety of gynecologic disorders, and sonohysterography can be added to increase on the sensitivity, and 3D ultrasound as well. So let's briefly touch on fertilization. Dr. Bach had obviously covered the sperm to a larger degree, but semen analysis just has to be done by all the guys. It just provides evidence of a male factor. It's not assessing sperm function. And through the clinics, we can provide a bit more detail on cause with respect to antibodies that may be present to sperm. And this is within the man. Sperm functional analysis, we're doing actually a trial wash. So we're practicing with the sperm to get a sense of how we can use it. And then a more detailed test of morphology, which is not generally done well within the community, to get a sense of whether this is sperm that can work clinically. Importantly, the test comes from one study out of interest, comparing 1,000 infertile and 1,000 fertile men. So it still dates back to this original study, but just quickly in summary, the more parameters that are affected, the more likely it is that there's going to be infertility with this gentleman. And if I can leave you with one thing, it's to ignore the morphology. If you look at the tests, you're going to see it in virtually all of them as abnormal, just not predictive of other natural or treatment-related chances. So we typically just ignore that part of the test, but a lot of these guys come in upset that their sperm doesn't look normal. And in some cases, if it's zero, I've been told that they're sterile. So just briefly with intercourse, bottom line is to try early. When you're counseling your patients, it doesn't hurt to try even up to 5 to 6 days before ovulation. Sperm will hang out, but the highest chance of pregnancy is going to be 2 to 3 days prior to ovulation. And there is increased pregnancy rate with increased frequency, and some evidence with daily. But after ovulation, there's a sharp decline in their chances. So if they can try more often, which is not always the case, then that may provide for better chances. And at home, I still think important for patients to follow their ovulation, whether it's with ovulation kits, urinary estrogens is with the computers. Mucus, I think, is still important. You don't find a lot of patients doing it, but it is actually quite predictive and starts to become very thin about 1 to 2 days before ovulation. But monitoring through the clinic, we often discourage, is not very predictive of conception. So this is another talk, different factors that may affect natural fertility. So you may want to provide this to your patients. It's all the data that's out there on natural fertility and different modifications, lifestyle and otherwise, that may help them at home. And patients really appreciate that, because ultimately the goal is to get pregnant at home, not with us. It's much safer if the patients conceive at home, given all the risks with advanced treatments. So it's important, I think, to have patients have the power to improve their chances naturally. So any questions?
All right, thank you so much, Dr. Roberts, for that talk. I know we gave you a lot to cover in a short amount of time. So there are some questions in the chat box, but just because it is 3 o'clock, what I'll probably do is ask you to answer